get started here. My name is Omar Khan, and on behalf of the faculty and residents who run the Christiana Care Global Health Curriculum, I'd like to welcome you. Hope you got something to eat and drink. I wanted to mention some of the folks who helped in putting this together. Dr. John Donnelly, Matt Eads, Dr. Carla Testa, way in the back. Carla, raise your hand, please. If you have any questions about the curriculum or the program, or for those of you who are residents who want to get involved, certainly please let us know. It is my privilege to introduce to you tonight one of the true experts in global health and global public health, my friend and colleague, Dr. Rob Simmons. As you see, Dr. Simmons is based at Thomas Jefferson University. He directs the public health program, the MPH program at the Jefferson School of Population Health at TJU. He has many, many accomplishments, and I won't list them all. I'll just note that he's a past president of the Society of Public Health Education. He's currently a Fulbright Specialist Fellow working in a couple of countries, which is a very prestigious honor, and he'll be happy to tell you more about that for those of you who are physicians and other healthcare providers who want to get involved in something like that. Rob is going to talk to us today about experiential global health education. This is something we've talked quite a bit about in this series, about how to take the global health education we provide in a didactic level, take it to the next level, and really get the experiences out of it. So Rob is going to enlighten us with his own experiences and hopefully some lessons and some words of wisdom for us as well. So with that, I'd like you to help me welcome Dr. Simmons.
Thank you. Oh, yes. Well, I need that help. Okay. Well, I'm glad to be here, and oh, thank you. Look forward to spending a little bit of time talking to you about experiential education, immersion education, in-country, in-community education, and focusing on experience. Want to tailor this as much as we can. I'm going to cover a breadth of different type of topics in different settings and environments. So please think of this as how does that possibly fit in your situation, within your, whether you're doing clinical work globally, or how it sort of fits together, and we'll try to focus as much as we can on your particular needs. There were a number of people from the University of Delaware that were hoping to be here, including pre-health students, undergrads, who unfortunately have an exam. So a lot of pre-med, pre-health students, and I said that I would tailor some of this to them, particularly at the University of Delaware, doing a separate presentation. There's a lot of resources here. I just want to mention that before getting into the slides and things. What I did is I included an article that you may or may not have seen in Health Promotion Practice. That is, I'm a co-editor of that particular department, Global Health Department, for that particular journal. And we did an article last year with a whole team focusing on two case studies, one in Rwanda and the other in Mexico, sponsored by two different universities, one Thomas Jefferson, the other is a public university, San Jose State University in Oaxaca, that does a program every year throughout the university in Oaxaca, Mexico. So what I did is I included, I included a copy of the extensive table, front and back, and that's what you have there. We're not going to talk about it directly if you have any questions, but some of the key concepts of what's the essence of doing good quality evidence-based work through experiential or immersion education in the medicine and health professions and public health. You may want to refer to that. Also, before getting started, I want to just mention some other resources in general terms before that. One is, if you haven't, those of you who are really into global health, the Lancet series, I'm sure you're all very familiar with, does a lot of things. They just came out with a huge document. This is only the executive summary. I haven't had a chance to read yet. The thing's over 200 pages, but it's Global Health 2035. So it's an incredible document about, and conceptually has a lot to do with how we want to, where workforce development, particularly in country and in the developing world, workforce development, capacity building, training, not just for our own training for US-based professionals, but particularly that reciprocal relationship and how important that is, and that's part into that report. There are several other journals and things. This issue that is included experiential education. I'm sure you're very aware, just the last year and a half, May 16th, 2012, JAMA special issue on global health. This year in September, another special issue on global health of JAMA. A lot of resources global health promotion in my area of health education. Now there's a separate journal that comes out. It's called part of the what we call the International Union of Health Education and Health Promotion and Public Health, and it's called Global Health Promotion. It's in 3 languages, English, French, and Spanish, and I want to highlight those things as examples of resources. So what I want to do, and I don't know if this will work quicker, I'll do it from here, but to go through some slides with you, and I want to start with education, and then we'll get into specific issues of clinical healthcare. So if that's not going to work, we'll do that. So let me talk about a little bit about some things about education. A couple of slides on that, and specifically, starting with the quote from Aristotle, as you can see, is focusing on, we learn by doing, and we all know that. That's where you have clinical rotation, in the clinical area, in the practice area, so much of that. John Dewey, who I'm sure you've all read and know about, one of the really grandfathers of education, talked about, and certainly experiential education. It's a lifelong journey. We hear about lifelong education. We know about auditory, visual, and kinesthetic, hands-on experiences, learning modalities. We learn by doing more than anything else, and sustain those for both skill-based and changes attitudes and things. Building learning experiences, and Dewey's work of discussing experiences via problem-based learning. You've heard the term, and using case studies, which I know you've heard the term and use all the time, but taking real-world situations and environments, whether that's at an individual patient level or if it's at a community level. What are the challenges? What are the issues? What are the factors? And of course, in public health and population health, not just at the individual and family level, what about the community? What about the systems or lack of systems and those issues that greatly influence on individual behavior change? So what Dewey did really is change the teacher's role to a facilitator and mentor. And this is particularly relevant with experiential and international education and experiences, to think in that concept of not giving information, but facilitating and mentoring and helping people learn in their own way by doing. Kurt Lewin's work, Behavior as a Function of a Person in Their Own Environment. This is back over 50 years ago. And then David Kolb's work. I don't know how many of you have studied or are familiar with experiential learning theory, where the learner creates knowledge through direct experience that's meaningful through the student, through guided reflection and analysis. So this is Kolb's experiential learning theory. Pretty simple concept about that as far as the cycle of that, but it's really true, and it's been well tested as far as a simple process, 4-step process that is a cycle as far as learning and continuous learning with experiential education learning. What are some of the goals? And this comes, you can see the reference there. It involves doing something personally significant and meaningful. So that means that the person is making some selection of what they're doing. That may be different from being in a rotation or doing something where you're not necessarily choosing to do that. You are being told this is what you're doing, this is what the rotation is, this is that experience. And that's a little bit different when we talk about experiential learning, that the person has a choice in doing so. They're selecting to be in this group to go to another country, for example. Students are very personally engaged, reflective thought, and you can say that about all education, but that's essential in experiential or immersion education, and that students write, discuss, and do something with their experience through that process. The whole person involved, not just the intellect, the cognitive part, but also their senses, their feelings and personalities and stuff, and as part of that, and it gets into issues like culture, humility, and competence. Students are recognized for prior learning that bring into the process. That's particularly relevant in experiential learning because they start from their own experience, their own culture, and their own background, and how that plays out. So when we have groups of people going to other countries, their experiences, even though they might be doing things in a clinic, in a community, in the developing world, etc., their experiences are a little different because they bring with their own culture or their own experiences in that, and we have to account for that. And then the importance of establishing a sense of trust, respect, openness, and concern for the well-being of our students is absolutely essential. So I'm going to pose a question. What do you remember most about your education? And I'm going to define education. You can include university, but let's keep it to undergraduate and below, not necessarily education and a postgraduate doctoral program and doing research, more of that level. A couple thoughts. What do you remember from your education? class and experience. Joe, please.
16 years of parochial school education.
Okay, so is
So
there
I
any,
remember nuns, you know.
okay, is there any one particular thing from those 16 years,
You know,
one
my large
incident?
knuckles from being rapped on by pencil.
Okay, all right. So you remember that
They were very
experience?
dogmatic, and this is the way things work.
Okay,
And you began to develop a view of life that things
Okay.
in this order.
this is the order, this is how you're supposed to do it. It's interesting that you certainly remember the experience of that ruler or whatever that instrument was
Oh, yeah.
on your knuckles, okay? Because that was part of that experience. What else?
Culture.
What else? What do you remember from your education? And it could be elementary education. Anything you remember from that? I have two things I'm going to share with you, my experience, but curious to your thoughts. Nobody remembers anything.
Good friends.
Good friends. So when you say that, was there a particular experience or opportunity to make that happen? And what level, if you'd be more specific, if you recall what grade you were in or how old you were and anything like that?
I was thinking of all my good friends in college, but then you mentioned elementary school. I remember making friends there back in first, second grade.
Okay, so the social aspect of doing so. So that could be looked at as how did they set that up? What was the environment? What was conducive for creating that friendship and relationship development over time? It may not have been in the classroom. It may have been out in the playground or whatever it is. Okay, anything else? One more, and then I'm going to share a couple of thoughts that I have from what I remember, which is back in, as my kids, ancient times. Please.
I had to miss traveling to Brown University, play on the turf on the roof because my organic chemistry teacher, Dr. Schweitzer, was going to fail me
Oh, wow.
in the 80s at the
Okay.
University of Delaware, so I will never forget that.
So you remember, so say it again.
He
What did
sat
you
me down
remember?
and said, you have a choice. He said, please, I need 15 minutes to make the bus. Let me take this quiz and I'll run and make the bus. He said, you will choose between education and sports, and you'll choose an
Wow.
And
So that was an experience. And what did you
because he was
choose?
going to fail me. Oh,
What-
I stayed and took my quiz.
Okay, so you chose education. Of course, you didn't. That might have been a sort of a forced choice of the alternative, but may not if you're failing in class. That's a great example. So it was from that experience. I'm going to give you two examples from my education. I'm from California, raised in Los Angeles. And so the first one is 6th grade in elementary school. And we're talking about late 50s, so this is a long, don't ask me what I ate yesterday, but I can tell you what happened in the 50s. I remember in 6th grade, so 1959, there was a experimental course. And I guess it was out of sociology. I didn't know what the terms, it was part of social studies. But it was experiential education for us, and we played the roles of baboons. And I was a young male adolescent baboon. And we all had different colors. They gave us wristbands and stuff. And what I remember about it is that we went outside and in the front yard had grass, and we would be on all fours playing the role of the baboons and the different roles that we each had. Well, now, don't ask me about anything else I remember from elementary school and any of that, but I remember that because I remember the experience. First of all, it was so weird and different back then especially, but it was an experience. I experienced, as best they could, experienced baboon behavior and what was the importance of that. The other thing so I do remember that. I don't remember a lot of details, but I do really remember that. The other thing that I remember is at university, my senior year, and it was the entire year, UC Santa Barbara. So this was in 1969. I was a poli-sci econ major, and the poli-sci you did also an experimental course that was a year-long course, and the first half of it you were playing the role of an administrator. I was an administrator for health, education, and welfare. That really dates me because that was before education got pulled out and became HHS. And I was an administrator dealing with issues of housing particularly and related to health. The second part of it was interesting. We played roles of the legislature. And so I was a conservative Southern Democrat, Williams Jennings Bryant Jr. I don't know if you know the history of that. And the interesting thing, why do I remember that? Well, because, first of all, it's fascinating. So we had to research, no internet of course, we had to research that role and their values and then during the entire semester, we were in that role. Well, why was it important? Because that role didn't just play out in the classroom. we all embody those roles throughout the entire semester. So when we had parties, we were doing deals and negotiations and, trying to, in that case, the Republicans were trying to move myself and a group of Southern Democrats over to switch parties, and to be Republican, and we played it out at parties and events outside of the classroom. That's experiential learning. So we tried to simulate the experience. In a sense, I didn't remember the term simulation at that time, but those are two things I remember. Why? Because I did them. It was not just something I was cognitively learning. I actually experienced it and identified with it. That's the difference in experiential education. So the other thing I want to concept really quickly is to talk about global, which is that when we talk about global health, you do not have to leave your border. That's why the difference, we're not using the term international health as much. It's still used, as we know at APHA, it's still called international health. Literally international is from wherever you're located, you're crossing the border, from whatever location you are, whatever. Global can be anything, and certainly this is in Philadelphia, one of our over 3,000 murals, but it's a community of children in this case, and a pretty important message related to that. We'll get back to that at the end. So it is global, and the multicultural experiences can be in one's community. And we emphasize that certainly in our public health program significantly, where we have Jefferson has a refugee health clinic. So both, not only our medical students, but allied health and our public health students work with refugees speaking multiple languages. In Philadelphia, we have 29 senior centers through the Philadelphia Corporation on Aging. At least 8 of those, if you go into those centers, you're not going to hear English. You're going to hear something else, but you won't hear English. So even though it's here in the U.S. and in our region in Philadelphia, it is global because the culture, especially if they're recent immigrants and refugees. So, and you can see some examples of that, of just examples I put together of what people from diverse origins, and diverse senior populations, disabled populations, military families. Certainly here, you work by the Dover Air Force Base, for example, and immigrant populations, and the need, if they're speaking multiple languages, that is part of global health. So I want you to be thinking of that, those types of things, and particularly the last part then is here in Delaware. Can you create experiences both for yourself, for your students, for others, that have a multicultural experience right here? Where would that be? Maybe it's down in Georgetown with a very different population. Maybe it's more an aging population on the beach or somewhere else. Or maybe it's with Westside Health or Henrietta Johnson or any of the other FQHCs or other environments. We don't have, in Delaware, we don't have public health clinics per se. They're privatized or FQHCs, etc. So aging and disabilities is an incredible experience here in Delaware. I worked with them when I was here as far as a cultural diversity and aspect of that. Think of that as part of global health as well, okay, in that experience. So it doesn't have to be only outside the border of the U.S. I'm not going to go through all of these, but I want to highlight, this is from AAMC, and this is called their Population Health Competencies for Medical Students. You can see the reference there was in academic medicine in 2010. Just to highlight some of the things, a little more on the public health side of what we do, but really this is for medical students. So things like assessing health status and looking at the role of socio-environmental, cultural, and other population level determinants of health. Various population health factors, quality, applying both primary and secondary prevention strategies, and identifying community assets and resources. This number 6 I want to highlight because I get this all the time, and our students, of course, are looking at data. And when we see data, when we're fortunate in Philadelphia to be able to have the Community Health Database, which is one of the unique databases that all of the public health universities, and there's several of them in Philadelphia, all subscribe to that through the Public Health Management Corporation. You've heard of PHMC before, but it's a very unique database because you can get down to data to the census tract, and it's in neighborhoods. So it's very unique for Philadelphia. That's not something all over that. But the key thing that I talk to our students about is, when we look at data, immediately we're looking at deficits or needs of community. In certain zip codes in Philadelphia, for example. Certainly here in Delaware, certain zip codes, certain areas. We need to think about, when we talk about solutions, we better start thinking about what are the assets. It's really easy for us to say what the problems are. We know those. What are the assets? Who can we work with? Who are the stakeholders? And let's work with those assets and be creative about what those assets and resources are. So that's important. Community engagement strategy, etc., quality improvement, ethical issues. So that's the source for that, and from AAMC, from Academic Medicine. I also want to mention from the Association of Schools and Programs of Public Health, well, we're part of that. That's only accredited schools of public health. Drexel's our closest one as far as a school. Hopkins, obviously, in Baltimore. University of Maryland, School of Public Health, but also the programs in public health in Philadelphia. That includes Temple and Penn and Drexel, as mentioned, the school, Jefferson, and others. So these are just some of the domains. I just highlighted a few of those. You have a reference there as well. But look at some of those domains and look at some of the competencies we look at. And we want to start with competencies to look at what is it where when we develop objectives for programs, what do we want to train them in? What do we want them to be confident? You can't necessarily be competent completely in all of these, depending on the experience. You know, if you have a 2-year Peace Corps experience, you can develop competency on some of this. But I want to highlight that, and then here's the other ones. Just take a look at the major domains of what we're looking at: social, cultural, political awareness, strategic analyses. So this is the global health, selected global public health competencies for that. Definition, we're not going to spend a lot of time with this. There's a lot of different ones. This is the one that I'm see more at is done. This is Jeff Copeland, former CDC director, published in The Lancet in 2009. But I highlighted, pulled out, this isn't the full definition, I just pulled that out a little bit to emphasize some of the aspects of what global health we were talking about. And then these are some of the, I highlighted this is Linda Freed's article that followed from Jeff's. Linda is, if you don't know, is a gerontologist, and she is the dean of the Mailman School of Public Health in Columbia University, just an amazing individual, and her and the whole team put together this article on global health as public health. You can see some of the things highlighted from that article. So clearly in global health we deal with these issues, burden of health inequities. It's not just health, but it's social determinants of health. These are things that you're familiar with. And these are important because in designing and planning initiatives, especially international initiatives or locally, cross-culturally, looking at issues that are important problems of the community or in the country or community that you're serving in. That has to be part of the process and the planning of what is done in any global experience. So what are we dealing with globally? You've seen this change in Manila. This, anybody knows what this is? You've probably seen this because it's gotten, when I've shown this to people, most people know where this is. A lot of people do if you're in global. Any idea? It's close. Same country. Correct country. It's in Sao Paulo. And what you can see is the incredible inequity right next to it. And a lot of that, we see that here, but we don't see it as much more of a melting of that. You don't see that incredible difference of inequities right next to each other, from condos and apartments with each one with their own swimming pool, compared to tennis courts to next to that. So I want to just mention key issues to think about globally. You know about this, addressing aging populations, non-communicable diseases, a huge area with our growth and development. This is a priority for World Health Organization, the whole non-communicable disease initiative and framework, and people addressing those. Aging populations are huge. And if we don't think aging is a big issue in the developing world, that is not true. That's because they don't have the infrastructure, most of the nations. So that's a really big challenge, and working with that, and so you might be in projects. I mentioned technology. Whoop, I forgot that that's in Spanish on the top. But this is from the Lancet. Anybody know what that is? Anybody know where that might be? What do you think that is on the right, that picture? It's an ambulance. It's in the Zambia. This is a low-cost motorcycle and ambulance. Ambulance in their term ambulance. But you can see the roads. You see two of them there. And this is part of growing technologies of how do you take the existing infrastructure, sustainable infrastructure, something they can afford, and apply it appropriately. And those are some of the issues with that. These are some of the barriers. I'm going to spend time on technology, but certainly aspects of technology are important today. So this slide is to depict the issue of the changing workforce and what are the future workforce needs. And it's not just what the workforce needs here in the U.S. As we look at it, what are the workforce needs and capacities needed in the country you would be working with, in the communities you're working with? That has to be asked when we develop experiential education, because it can't just be for us. It's got to be for them as well, and how do we structure that? So this is just a slide showing you a world that's a little bit old, but it's a slide of the world distribution of health workers. So you can see where the distribution is, not surprising. There are a couple of surprises. If you look in South America, next to Brazil is Bolivia. So it's a little surprising that they have a really high level, at least in these 4 categorizations, of where their distribution of health workers. Part of the problem with this slide is how the country defines what a health worker is and what their training capacity is varies tremendously on how this is depicted. So training the future, what are some of the basic things? Well, clearly the area of basic education, part of the Millennium Development Goals. You can do formal preparation, clearly undergraduate, professional, graduate. Certifications, continuing education is all part of that education process, and then training, in this case, primary care workers, physicians, nurses, allied health, community health workers, and health promoters. Tremendous growth of experiential and immersion programs, huge interest, and that's going to lead to some of the examples I'm going to show you about that at all levels, including undergraduate education. It has just exploded. There's good and positive and not so good things about that. Several articles about that. AAMC, by the way, it's dated a little bit, but it's still very relevant, had a whole special issue in February of '08 on global health and included articles on experiential education. Certainly clinical programs. I'm very familiar with those. Physicians, nurses, allied health, pharmacists, etc. I mentioned the articles, and a ton of private programs. So that young people going into pre-med, pre-health, they're paying privately to go to these 10-day programs. And the programs are supposed to be not just the health experience, but a sociocultural experience, etc. on that. And then as well as the more formal and more public programs. What are the key learning opportunities in experiential learning? I'll just let you take a look at this list. I know I'm sure you're familiar with it. These are the things we have to focus on for people, what our goals and objectives are in creating and developing these. The application of things we learn in the classroom or the things we learn in clinical environments, how do we apply it to other settings? Knowing you're working in resource-poor environments in many cases. Thinking of systems, thinking of sustainability, absolutely. Going in, there's a lot of criticism of places where physicians and others go into there, do a quick fix, do their surgery, leave things. Sometimes they leave debts and responsibilities like equipment. Great, what happens, who repairs that equipment? How do you get the resources? How do you get the training? Can you get the parts? So by doing so, what are the implications and the dependencies that are created if we do that and try to fix a problem by going in for 10 days and doing all these surgeries and all of that stuff? It raises, and it has been raised certainly in the US and around the world, some real questions about what are we doing and what's our real purpose if it can't be sustained, if we're not training and building capacity of those countries to do it themselves rather than relying on outside resources. What happens when those resources dry up? So those are things, certainly aspects that we'll talk more about, reflection in journals. You can see I'm talking very fast because I'm trying to get through as much of this. Building self-efficacy or self-confidence and leadership skills. Great opportunities to do so. And that should be part of the goals and objectives of any type of experiential global health education. So there's several components of it. I highlighted this article, so there's a reference to that. It's not solely from this, but we try to look at in the table, that example that you have there, looking at preparation. And just take a look at some of the things that are part of the preparation. There's many more. This is labor intensive. This is preparation of bringing people to another country has all sorts of issues. So it's not to be taken lightly, whether a person is just going as a group and trying to get funding for that and your experience globally, but also for those who might be planning this as an educational experience for that. All of these types of preparation meetings, developing that relationship, it is a relationship, like any other relationship. And to be sustained, you have to have, it has to be a win-win for the other countries you're working with. You have to find the right infrastructure. I'm going to use some examples of that. Developing community-based and clinical types of projects. For that, you have language and communications issues clearly in most of the countries, and certainly aspects of ethical standards and practice. We'll talk about that. So more preparation, the pre-experience education. What we found, the evidence is really clear. The good programs do so much stuff up front. Students at all levels that are going to other countries, programs that are successful, are the ones where there's all this preparation done ahead of time. Students learn about the country, they learn about the culture, in some cases they get language training ahead of time depending on the environment. They get connected. Often there's communication by Skype, etc., with the program in country. The planning and preparation is absolutely the key part to make it successful. What about the time frame? What about training in country personnel? A couple of examples of that. And logistics planning, MOUs and memorandums of understanding, of agreements, visas, immunizations, flights, housing. You know all about those things and the challenges of doing so. The in-country experience, the contingent, being flexible, because you've got to have contingency. So ongoing communication during that experience, however long that experience is, or a set of them. If you have people, what we do with the Rwanda project, we'll show you a few of that. It's interesting, it's going on now our 8th year, working through the National University there, and the medical students typically go a little bit separate based on their schedule at Jefferson. They go in June, early July. The public health students usually come a little bit later in July, depending. Sometimes they overlap, sometimes they don't, but it's sort of a series of things to do that. So how do we infuse that? The students have to journal, they have a responsibility, and it's student directed. I mean that by those who go there, it's typically during the summer, they are the ones who educate. And for the new students, first-year students, for medicine, it's clearly they're in second year. They were there in the summer after first year, and they're educating the new first-year students on what it's about and encouraging them to participate. And obviously, post-experience, student journals, papers, presentations in class and independently. How do you do lessons learned and share that? What about education, publication, all sorts of things, and training of other students and professionals. So let me tell you a little bit. This was one of the 2 case studies, since I'm more familiar with the Jefferson one in the article than I am from the San Jose State one in Mexico. But this is called Jeff Health. I don't know if you've heard of that. Anybody heard of this before through Family and Community Medicine? So it's coordinated through Family and Community Medicine at Jefferson. Jim Plum and his daughter Ellie Plum and others. So it's a group of allied health students in different medicine, etc., public health. They spend 4 to 6 weeks in 2 particular communities in Rwanda, involved in community health assessment, education, infrastructure development initiatives. I won't go into detail how this started, except it came from barefoot artists. And you look at the history, fascinating aspect of history of Rwanda is just in a completely very positive change from what it was 20 years ago, with all of the internal civil wars that they had and all of the horrific experiences back then. So these are some pictures of examples of this. The left-hand top is a team of medical students, including, I believe Ellen Plum might be that, Jim's daughter, who's a lead on that article. And this is where they're building a hut and environment. I'm not sure if this is a rabbit hut or what exactly they're doing on that, but they're building some sustainable work in Rwanda in the lower right. These are our public health students that came back from last year who have done their work in Rwanda on various community education projects. The other part of this that I want to mention is these are the Rwandan medical students. So we work with the National University of Rwanda and their School of Medicine, and as part of this reciprocal relationship, 3 to 4 students come every year. It's always from November to January, so it's always during a holiday period, but they come, these are 2 different groups of Rwanda medical students, and they sit in on our public health classes. They don't do a lot of clinical work, but they sit in on medical education courses. So they feel that they're gaining too. It's not just for us and not just for our students, it's their students and their future, in this case medical leaders, are learning from the experience in a reciprocal relationship. Okay, so that's generally sort of the sense of the overview of that. What I wanted to do now, and really thanks to Dr. Khan Omar for put together an incredible panel just last month at the American Public Health Association on medical education, and asked me to in small capacity, help moderate that and be part of it. And I was just blown away, including John's presentation and co-authors with Omar and Chris, about the different levels of global education that was discussed. So as a follow-up, including John, I emailed them as, gee, you guys are doing great. You know when a session works well at APHA, when you go on a break and half of the group is still there talking, and stuff. They're more engaged than they're getting off on their breaks. So you know, as I emailed you, they say, hey, it had to be pretty good. There's all these people still staying in the session, and they're on their own time. So they were all nice to share some of their slides and stuff. And I thought, because it's such interesting examples, I thought I would, especially focus on medical education, I thought I would share that. So I want to highlight, John, I hope I've captured some of the essence of all the slides and the things that you talked about representing Christiana, but I want to highlight some of that. So this was from the resident survey that was done last year, 2012, and you can see the data here. You probably had discussions already and talked about that. I'm sure as far as the interest, no surprise, huge interest in global work. Why is it important? In this case, we're dealing with residency, and you can see some of the data. I just pulled sort of pulled things that I thought was really important based on hearing and seeing your slides and what you recommended. So you can see some of the things here right at Christiana that why global health experience and residency are important. And then a reference article, why are residents, what are they more likely to do? This is sort of our projection of, well, does this make a difference for residents? They go on this experience, what happens? I thought these 5 bullets here are pretty important. You get, getting people practicing primary care, you know who they're serving, pursuing careers in public health. I'm excited about that, as that physicians are doing that as part of their residency experience and going beyond, participating in community service and actually working overseas, and many of whom I'm sure that won't be the last global health experience they'll have going forward in their careers. So what about structuring as part of that? So we took some of the stuff that John, you presented, and you can just take a look at the aspect of this, starting with the learners themselves and developing and designing it, and using an interdisciplinary model to try to work interdisciplinary and transdisciplinary. That's really important if you can possibly do it. So it's not just a bunch of physicians, but it's nurses, it's allied health, it's community health workers, it's all sorts of, as a team. Just as we're trying to do that here with, accountable care organizations and patient-centered medical homes and working as a team, that is modeled, and actually we have a lot to learn from other countries of how they work with teams and the various roles that people play in their health and healthcare systems, including in the communities they serve. And building partnerships locally and globally, and aiming for sustainability, which is really every single type of program. So this is a next step slide that you had that talked about where you're trying to go. And so I just pulled off some of the key things, talked about mentoring for future training, possibly some getting a public health degree, going in the Peace Corps, all sorts of opportunities, work experience, and sustaining a core group of educators across various disciplines. This one was, and also the interesting thing about this particular session, we had representations at different levels of education. So we didn't get into undergraduate medical, pre-medical students, from all parts of the country. So we had Delaware in the East Coast, we had in the South, in Southeast, University of West Florida, representative from the University of Minnesota, up in the Midwest, and then Touro University in Northern California. So it was a really interesting mix across just of the 4 panels. I don't know if you did that intentionally, Omar, but it was a great example of it.
Yes.
Okay, I know you did. So, and this has to do, on the lower left, by the way, they have a whole thing called International Health Connection. I have resources for you on that. I thought it was interesting. They're titled Transforming Medical Trips into Significant Learning Opportunity in Global Health. So you can see the medical students from FIU, College of Medicine, participating in Haiti. This is just recent. They've only done it for a couple of years. Under the auspices of what they call the International Health Connection, a nonprofit organization. So they work with a local nonprofit and an international nonprofit in this case. And you can see their comment about first intended as a mere international experience. They've turned into something more of comprehensive training for future physicians. So I'm just pulling a few slides that I thought were interesting. That this is some of the things that they do. And you see that it's not just about healthcare. They include the environmental issues. They're dealing with art, culture and music, religion, in that experience, much more broader experience than just working in the clinic as the sole focus of what they do. Some of their activities, some data. So it's a small program, as you can see. They've just done 9 trips in Haiti, 2 in Peru. I'm glad to see that they had 5 MPH students there as well. They do some mobile clinics. They're working with setting up an orphanage school and school buildings and existing clinics in urban and rural areas. So it's not just within the healthcare system. They're looking at broader systems outside of the educational systems, such as healthcare, and that they've treated 1,400 patients in Haiti and Peru to date with more than 2,000 encounters. This is some other examples of that, pharmacy, and people playing different roles. And it's not just medical students. So I thought it was really fascinating what they're doing, and it was great to learn from that. These are some of the student comments. So I always want to highlight some of those. Let's take a look at that for a moment. How do they define key elements of success? Building objectives to meet their competencies, medicine and global health competencies, various activities, their respective curriculum, internships, etc., cross-cutting competencies in social justice and health equity, cultural competency, continuity of continuity, of learning experience, so it's not just a one-time thing, but hopefully followed up. Do cases, additional research, various scholarly publications and presentations as an outcome measure of what they do, and developing various evaluation tools. These are some of and it's similar to the other slides that we put together as far as some of the issues and protocols, diagnosis, language issues, they have pharmacy that highlighted as a big issue, one of their services, and ongoing monitoring and feedback and evaluation. Some of the barriers where they want to improve. Okay, so language is certainly, depending on the environment where you are, can be a major factor, and then working with translators. That is in San Jose State, in that they're part of the case study of that article, all of those San Jose students are all Spanish speaking. So that was sort of the requirement, you had to be fluent in Spanish. And in San Jose, that's a very multi-ethnic and a very heavy Spanish speaking population, so they didn't have a problem with that. For Rwanda, that the work is done through translators, and still do it, but it does make it much more difficult and challenging, and you have to deal your expectations a little bit. And then daily brief, they do a daily briefing. I thought that's important, something bringing people together. I'm going to switch then to the other coast, and this is Touro University in California, this is a slide just showing the breadth of how many different programs in the public health area, schools and programs have at all levels, certificate programs, master's and doctorate, graduate level, how many different programs there are. It's just exploded. As I mentioned, in private, it's certainly exploded at the university level, both for undergraduate and graduate. Similar, interesting, they also use the same reference, but students doing internships, what do they do? More likely to, and I thought this was interesting, their data, what they choose from their student perspective, what they do. They define this as the moral obligation, and I think that's an appropriate way to look at that. There is a moral obligation here to, first of all, do no harm, no surprise there. Don't create dependency, build capacity, and it's something that they prize, that it will get sustained when our students or our people leave. That's essential, because if not, we're creating dependency. And that's not the purpose, and that's what we get criticized for. Oh, these are great programs, they're for the US. Or worse, they're for our native people, which I always have a problem with when I get students from other countries, developing nations who come in our public health program, because frankly, I always get concerned about the brain drain. Are they ever going to return to their country? It's going to be great for the US, they stay, and many of them unfortunately can't control that, even though they might say they're going to go back in Nigeria and they're going to be leaders in public health, but I can't control whether they're going to stay in Nigeria. And I question personally, is this really helping? We get all these great people from around the world, and they come, and they're in Philadelphia, they're going to go back to their host country? And if not, are we really helping them? It's great for our numbers and stuff, but we're helping them personally, but are we really helping the world and their country? And I really have to question it. I don't have a good answer for it. We try to screen for that. So, that this is not the purpose, is just to pull people off from other countries when they need them and be trained, and then need them in their host country. Something we have to think about. Okay. I don't know if you've heard of this thing called WAIT. It's the Ethical Guidelines for Global Health Training. The working group of that. There's the reference for it, the Crump article. There's seen it, but it's used by several universities as a framework for reflection and improvement in global health. Some examples of what the weight guidelines are. So you can look that up. It's really, they're great guidelines in developing global health training, and there's the reference for that in the American Journal of Tropical Medicine Hygiene. Dimensions to consider for planning ethical internships. Just take a look at these. A lot of this is the logistics part of that. But evaluation, obviously. Oversight from the sending institution. So what is that oversight from our institutions? What is that oversight and support systems from the institutions in country, and making sure that's not, especially on the latter point, it's not an overburden on the part of with limited resources in that host country. Absolutely essential. So there's online assessment tools. So these are some of the questions. I just pulled off some of the questions from the assessment document. It's all online there. It's a very large document. You'd not be able to read it on the screen. So I just pulled out some of the key questions from that assessment. I thought they were pretty good ones. And I like that last one. What do we train before we have our students and residents and others go over to other countries? What do we train them about cultural competency and their ability? And you could take that same question and ask about what training do we do in working with different populations right here, not just only outside the U.S. I thought I'd mention this. So this is one of the competencies as part of the WAIT initiative, this one particularly on ethics and cultural competency, and it's just an example of what the feedback is and the sort of response in this case, and you can see that response, and this helps the university to develop this in this particular case using these guidelines in this particular competencies, and there's a whole bunch of them. So it's something the universities really need to, and the clinical environments really need to think about in designing these. What are we really trying to accomplish? And using this as a great tool. Okay? And this is the goal of some of that training and using those ethical guidelines. Okay, the next one really quickly, just only a couple more of these. This is from Tricia Todd from the University of Minnesota. And this is experiences from PreHealth students. And this was, I thought, very interesting when you talk about PreHealth students, because now we're talking about undergraduate students and the challenges. And I was blown away. I don't know if you were, John, but oh my goodness, they're doing this, and I understand. I think the audience clearly understood what the challenges are that they face, why these guidelines are so important. So I mentioned the huge growth of that, the need for program structure and partnerships. It's sort of like anybody can just do whatever they want, especially private sector, and create these environments that students and their parents are paying a lot of money to go to these countries for these 10-day, 2-week experiences. And what do we expect them to do? And the importance of adherence of that and developing tools or resources. This is a wonderful tool that they've created at the University of Minnesota called Health Careers. I'll highlight a few of these. This just talks about the growth. You don't have to worry about the numbers, but more of the growth of undergraduate students. And many of these are pre-medicine, obviously, and pre-health professions. What do students want to do? So these are some of the things of their interest and what they're trying to reach from our students. And these are all wonderful goals and objectives as far as their particular interest. But I was blown away with the type of experiences some of these students do. And boy, is that a challenge. And so, but wait, these are undergraduate students doing this stuff. Now, it's understandable. We had some discussion about that because in resource-poor areas, a student, a 19-year-old, can be there and may be asked with no other resources, deliver this baby, do this with no training. And I'll show you one quote from this. Is, oh my goodness, are we helping? Are we? So I thought it was interesting. So they developed a program called the Global Ambassadors for Patient Safety, or GAPS, and learning, especially undergraduate students, to be a learner and not a doer. Now this is hard because, and we talked about it a little bit, is that you're in a country and a student, let's say a 20-year-old is there, and they're asked to do something. They're so appreciative of the opportunity to do this, and you're asked to, I need help here to do this. Could you suture this up? And you've never done anything. They're trained to do this. How do the students respond? How can they respond without being offensive to them when they need help and there's nobody there to do it? So it's a really big challenge for that. So there's a whole group of standards and a reference for there of doing that and developing that. We won't have time to talk about it, but I thought it was fascinating, the procedures and stuff, some of the other ones, ethics, health, safety, risk management, and program resources. And this is an example of the standards. So there's actually documents of that called the Forum on Education Abroad. I hadn't heard of that. Through the U.S. Department of Justice and Federal Trade Commission Standards Development Organization for going abroad. So my last slide, I believe, takeaway messages. What are those messages? And this is something that I took away from in both the experience of that particular session, but really what I think from a global health experiential opportunities aspect and experiential learning, that it's a wonderful vehicle for interdisciplinary learning and impact on knowledge, attitudes, belief systems. Students come back changing their beliefs, which is great because it's opening up their eyes to do that. They're reaching a population. It can be done right here. Go to Georgetown and work with, I don't know if LADED is still operational and others, but work with a population where English is not the language that they speak. And if you've never experienced that, and people from, let's say, coming from rural Mexico or other parts, and that's a different experience, and that's good. All of us need more of those experiences. Our younger students and others need those experiences. But it's a challenge in developing that. Experiential education globally, various education requires very much strategic planning and assessment. It's got to be reciprocal. I've highlighted that, including training and capacity of in-country individuals, and that students and professional participants in both countries should be the drivers of the experiential learning. So what's really important in that Rwanda project, those medical students, what they do when they go back to their university, and that communication level, and hopefully that has a positive result when in Rwanda, when they go back to their university and their training, the influence they've received in the United States can hopefully, for the better part of that, can be very positive. So my last slide is back to that original slide that I showed you about Philadelphia, but I rechanged that title called Local Health is Global Health. This could be, frankly, any environment. Many of them as far as the aspect of culture and bringing people together as far as experiential learning. So that's all for the slides and stuff, and I'm really open for some discussion if we have time and questions that you might have about experiential education, your questions, your experiences. So thanks a lot for being here. At this point, open questions. Joe, please.
Rob, how do you fit these programs into the curriculum of a standard medical school? In other words, there are certain blocks and so forth.
It's a great question. I can only give you my very limited experience and others who have had that experience, how you fit it in. First of all, it really has to be a commitment on the part of the administration, both the university as a whole and the medical college. How does that get driven? It's getting driven right now at Jefferson, I can tell you, by the medical students in the area of medicine who are driving that. They don't feel we're doing enough. We're still working on developing a global health center and a website and everything to do that. We have modules we've developed to focus on global health initiatives and stuff. The students typically, no surprise, the medical students have opportunities in that summer of after first year and in their fourth year electives, where they can go to do global health work. But there has to be a commitment, there has to be faculty support, there has to be infrastructure, there has to be funding. The 4-door grant funding is used particularly for the medical students and public health and allied health for that summer experience, but it's limited. The students then have to do fundraising. There are clubs and groups and to enable to just experience that. So it really is a matter of commitment. Now, not every university can get like North Carolina Chapel Hill, what it did, and the Gilling School of Public Health and Global Health. So there's a whole commitment on that global area. So it's really part of the whole infrastructure. My limited experience is obviously that summer after year one, traditional, we're talking about traditional medical education, and that's changing. But also, of course, in the fourth year electives, hopefully it gets more integrated. I can say the integration comes at the global level because medical students are involved. The medical students have their own part of a refugee health clinic and immigrant clinic working with the Nationality Services Center in downtown Philadelphia. So the medical students themselves are running their own thing. Pathways to Housing, working with homeless populations, that out-of-family community medicine, the medical students are leaders in developing that. So the departments, obviously the dean, the department chairs, the infrastructure has to really be supportive of global health. And frankly, it's a competition, and take advantage of that competition, because to compete with the top, They get, and Jefferson, as you know so well, and others, very difficult to get in. They get about 11,000 applicants. They interview 1,000 people. It's an amazing operation. They offer 500 and they take a class of 263. So, and they don't need to recruit more, but we talk about getting the quality of people to be future global health leaders. That's the mission and goal of our school, is you want to get people with those experiences. We have a population health college within a college, which is a 3.5-year elective, scholarly elective at no cost to the medical students, that we embed public health courses in that. Those cohorts, we're now in our 4th year, we got 5-year HRSA funding. The vast majority of those Jefferson medical students have had Teach America, AmeriCorps, or Peace Corps experience prior to going to medical school. So these are young people that are really dedicated and interested, and everything is so global. So I think students can actually drive a lot of that, but I don't know if I've answered your question, Joe, as far as...
No, when I was a student at Jefferson, we considered coming to Delaware as going to a third world country. That's 50 years ago.
Right. So other questions or comments about this? How does this relate to you and your interest, or what you do, or anything you might be doing in the future?
I just find it interesting. I did travel to both Africa and Honduras in the past, in 20 years prior, and I'm an x-ray technologist by trade, but I went down there to teach. But in addition, I started IVs. I helped clean supplies.
Sure.
I built a walkway so we could move the machine out of the little room that it was stuck in to take images of people that were in traction that had never been imaged before. But I felt comfortable that I could go in and start IVs, that I could do chest clapping, the old-fashioned chest clapping, because they had nobody, like you said, they had nobody else to do it, and I was there to do it. Now, we've recently traveled to Haiti, multiple years, just recently, last year, and they're very particular about what you can do. You have to be credentialed, you have to be, and I found a shift in these developing countries that you cannot send anybody to do anything. You have to be credentialed, and they're requiring credentials, they're requiring people to be educated in what they're doing. They don't want me to do nursing procedures. They don't want nurse to do x-ray procedures. They want people just the same as we do. They want their standards to be higher. And I think it's good, but it's also frustrating for people that want to go and work in these communities, in the bush, so to speak, and they have the education, they have the know-how, but credentials they do not have. And I think sometimes with these students, it's nice to see their energy and their passion and their desire, but I think they're pigeonholed into what they're studying, and I can see both sides. I can see these third world, and I say third world, and I know that's a passe phrase, but I think we need to get out of that, what we do, and forget our biases here and our levels of what we expect, and just go over there with an open mind.
Well,
totally.
agree, absolutely. And that's, I would look at that of what you said as in a very positive way, that they're trying to meet their needs, not our needs. Because the question, of course, and I just don't want to pick on you specifically, but just that example, when you did those things, did you train other people so that when you leave, they can do it? In other words, you build that pathway. Is that pathway sustained? Does that still exist? That little thing, if it is, that's a very positive thing that they can use. But if it isn't, we're helping us. How are we helping them? And if that's our attitude, is just we're in it for our training, for our benefit, so we're better clinicians. That's great for us. How does that help that country? And if it doesn't, if it creates a dependency, I use the equipment example and all of that, that's why it's important to bring people over here as part of that reciprocal relationship, and I think that's an important aspect of that. The other thing that's really important is interdisciplinary teams, is working on that. This is a big issue with so many of our medical students in that first summer go and work globally, right? And some work in the U.S., Appalachian, different things, but they're not doing, they shouldn't be, doing clinical work, they've had 1 year of medical school. But depending on environment, so they're doing community health assessments. They're like, okay, they're working within a clinic and observing and stuff, but then they're also going out with health educators and stuff and learning how they can train others and working with promotores de salud and all of these things so that they can, and they learn about the system and work with those systems. They do a lot of education. So a lot of that is education and hopefully building capacity and training so that they can do it themselves. Because if we're creating dependency, this has been the criticism of not just the US, and Japan and others of creating that. From a public health perspective, if we look at, I don't know how familiar you are with the model in Cuba of where the Cuban physicians, both in Africa and Latin America and others, this is, and there's a wonderful, it's a little dated, but it's a really good thing to see. It's called Salud, 2006. From Cuba, and there's a little bit of propaganda there. You know, we have to look at that but it's not completely, because there are physicians on that video that are criticizing what the Cuban government is doing. So, well, gee, if they let that in, it can't be completely 100%. But what do? They live in the community. So that means that a Cuban physician is going and living in the jungle somewhere with that community or in that rural area. Now, are U.S. physicians going to do that, or any of the healthcare providers do that for any extended period of time? It's a completely different mindset, a completely different way to do that, and perspective. So it makes us think about what are we doing things for? You know, what's our objectives, and if it's just for us,